You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that had, has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and share it with friends. Thank you.
Hello, this is Richard Jacobs with the Future Tech and Future Tech Health podcast, and I have Mark A. Cruz, D.D.S. We're talking about the Inspiratory Flow Limitation, its effect on sleep and breathing and wellness. So we'll get into the details of that, but Mark, thanks for coming. How you doing?
Doing great. Thanks for having me.
Yeah, so what is IFL? Let's begin with that.
So, it's a term that stands for Inspiratory Flow Limitation, used in pulmonology and sleep medicine. More often refers to upper airway resistance syndrome, which is its own nosologic definition within the sleep disorders breathing spectrum. So a lot of people think of obstructive sleep apnea syndrome as breathing or sleeping problems, and yet that's really to the end stage diagnosis of a whole spectrum that has a number of different conditions or nosologies.
Yeah, I've heard that apnea is defined as, stopping breathing for 10 seconds or more a certain number of times in an hour. I guess a certain number of times in a sleep cycle as well, or, a sleep period. Or, do you have a more formal definition of apnea, or is that close enough?
Actually, the definition of an apnea is stopping your breathing for 10 seconds or more, accompanied with a drop in oxygen saturation of greater than 4 percentage points. The number of times that happens per hour is what gives you the index.
Or the hypopnea index?
No, the apnea-hypopnea index. So the apnea-hypopnea index includes apneas and hypopneas. Hypopnea is another major event, and there are a number of different definitions, but one of the more common ones is a drop in airflow, 30 to 50% for 10 seconds or more, again, accompanied with a drop in oxygen saturation greater than 4%. So you have apneas and hypopneas. The number of those that are counted within an hour gives you the apnea-hypopnea index. The respiratory disturbance index is the apnea-hypopnea index plus the smaller events called RERAs, or respiratory effort-related arousals. So that's defined as a drop in oxygen saturation between 2 and 4%.
Yeah, I've observed that. We've seen it in movies, and I've seen it with my parents and all that. They go, they kind of snore and they seem to wake up partially and then go back to sleep. In the movies they'll do that. Like, let's say they're trying to take someone's keys without them waking up, and they go, and they'll move and murmur or something like that. Is that an arousal or an example of one?
Well, that certainly is an arousal. Whether you would define it as a RERA is another case, because RERAs are typically you have an EG that is that you could see beyond just the actigraphy, the movement, if you will. If you're using high resolution pulse oximetry, you have an algorithm that will define a RERA, effort-related arousal, that doesn't have an EEG associated with it, but it's associated with the change in the heart rate, if you will, that you could pick up on the pulse oximeter. So, but yeah, it's an arousal. And inspiratory flow limitation can cause an arousal. And why it's important is that obstructive sleep apnea syndrome is really the tip of the iceberg, if you will, of the sleep disorders. And people are now starting to recognize the much more common form of it in the form of upper airway resistance syndrome that can happen to a teenager or a young healthy female in large numbers. And yet it's not too much recognized by the third-party payer, and that's part of the problem. And so seeking care for it, from or benefit from your medical insurance for it is a little bit of the fly in the ointment, if you will.
Let's say, I wake up every day tired and I have all these symptoms, and I go, my doctor sends me to do a sleep study, and for some reason, I had like 29-second apneas or something. Nothing was 10 seconds or longer. For instance, would they just say, "Oh, you're fine, have a nice day," and insurance wouldn't pay for anything?
Right. That's just one example. It could be an OD4 event that's defined as an event greater than 3%, 3 seconds less than 10, and those are very, very common, and they would never be scored. So you can have somebody that ends up having a respiratory disturbance index of 2 or 0 that is very fragmented in sleep, and they're rather symptomatic and sick. They have what's called the functional somatic syndromes, TMD, muscle aches, irritable bowel syndrome, anxiety, depression, yada, yada, yada. So all those symptoms. And so I would not send them for a sleep study. That's why I screen them with high-resolution pulse oximetry. I learned many years ago that if I send them to a sleep study, it makes the problem even worse, because now they have a physician that said you don't have a sleep problem when they're thinking of a sleep problem being obstructive sleep apnea. They may be true in that regard, but they do have a sleep problem, a sleep breathing problem. And I'll be more specific and say they have a breathing problem that's resulting in fragmented sleep. And why that's important is that we now know there's studies that show there's causation for serious conditions such as cancers, metabolic dysregulation, cardiovascular remodeling, even if you don't have obstructive sleep apnea. And with children, it's especially critical because just having sleep fragmentation for whatever reason is enough to cause inflammation in the brain and increases in inflammatory markers like IL-6 and alpha-necrosing factor and specific C-reactive protein that really has adverse effects on children, from failure to thrive to cognitive problems, anxiety, ADD, ADHD, et cetera, et cetera. So there's some serious conditions just with sleep fragmentation.
So all right, let's define a little bit more. So sleep fragmentation, one example could be, the adult or the child doesn't sleep through the whole night. They'll wake up 1, 2, 3, 4, 5, 10 times, even if it's only for a few seconds, and go back to sleep.
No, sleep fragmentation would be they sleep all night, but they don't necessarily have to even wake up. They just they're pulled out prematurely from N3 sleep or REM sleep. And why that's important, and there are recent studies that just came out even a few months ago from Europe. They're pediatric journals showing that you can have failure to thrive when you have that. So what would be the reason? And that's, let's say, for mouth breathing, it's because the hypothalamus releases the metabolic hormones and growth hormone during N3 sleep in short periods of time. So if every time you go into that deeper sleep, which is when the airway is more vulnerable to collapse, just the mere threat to collapse from the autonomic nervous system in the brainstem is enough to pull you out of that sleep into a shallower sleep. So you may never wake up, but you just don't get that full, healthy sleep architecture. You sleep for 10 hours, you wake up very tired and fatigued. And it could happen 30 times in an hour.
So how do you evaluate someone that has this problem when they won't even know it? I guess someone like this would present to you and say, "Hey, doc, I sleep 10 hours a night, but I still wake up and I feel like I haven't slept." And then what, if they say something like that, for instance, what would you do?
Yeah, I see those patients every day. In fact, they come in from all over the country, and they've been previously, quote unquote, diagnosed or ruled out for Lyme disease or molds. They know they have fatigue, and no one could figure it out. They're primary care physicians and specialists, and they're still tired. No one could figure it out. But no one's asking about sleep quality, let alone quantity, but sleep quality. And so the way we look at it is we do a very specific airway examination, looking at 9 different areas within assessment like Shervin's pediatric sleep questionnaire as an example. And then so that's qualitative, and then we get quantitative data with, let's say, a high-resolution pulse oximeter. So we can actually see quantitatively what's happening, not so much looking at the apnea-hypopnea index or the respiratory disturbance index, but looking at the cardiovascular modulation as it presents with the heart rate. So you see these heart rates that are 50 to 60 beats per minute, but then throughout the night, they're getting these huge spikes up to 110, 120 beats per minute that comes down immediately. And that's happening all night long.
Right. Yeah, I guess that cycling of the heart rate causes stress on their whole body amidst other things.
I wouldn't call it cycling because that's a very specific term, but it's heart rate variability. Yes.
Okay, gotcha. All right, so you'll run these tests on the person, and then what kinds of things do you find that are addressable? What can you do? What kinds of things are common that people like this have? What kind of problems with their airway, or what can you do about it?
So what we look at is, once we do a thorough assessment looking at structure, function, and behavior, we have an algorithm that we teach that basically says the first thing we need to do is unfragment sleep. So to prove our quote-unquote hypothesis is if we can unfragment the sleep, then we've shown that it's related to their breathing and sleep. So, for example, a kid that's wetting the bed all the time and getting up with night terrors and they snore, or an adult that has similar symptoms. They have nocturia. They have daytime fatigue versus sleepiness, two different things. If we can go ahead and use either a trial oral appliance or a trial CPAP, and then check them 2 weeks later, redo the high-resolution pulse oximetry after we titrate either of those two approaches, and then look at their changes in their clinical signs, where let's say their fatigue severity scale shows at baseline that it's severe, moderate to severe, and then after a week they come back and it's half of that. They know that they're sleeping better. But it's not just about the device. It's also looking at sleep hygiene. Are they on their iPad till right before they go to sleep? Are they eating an hour before they fall asleep? We'll also look at breathing function. So we look at 5 competencies, and we believe that there are 5 things that every human being should have, and there's good evidence to support the physiology. And one is they need to be able to breathe through their nose, exchange gas through their nose efficiently, 90% of the time, very easily, with minimal effort. Number 2 is they need to be able to maintain a lip seal. So they have lips competence with their tongue on the roof of the mouth, which is the 3rd competence, and that's driven by the 5th cranial nerve. The 4th is a non-collapsing pharynx during sleep, and the 5th is diaphragmatic breathing. If any of those competences, things that should happen easily, day to day, moment to moment, are threatened, then you have compensation. And those compensations are what result in the signs and the symptoms that the clinician sees when they come into the office, all the things that we list in the airway exam. And so we want to reestablish those competencies and kind of unravel the compensations. And then that's how we know that we're are successful. We're measuring outcomes that are based on the patient versus the provider outcome. And so we document that. And there are any of a number of things you could do, from just therapy, from breathing behavior, addressing breathing behavior with a capnometer, to myofunctional therapy, to creating tongue space or oral volume.
Can you re-step through the possible remedies, and what does that mean? What's myofunctional therapy?
Right. So one of the confusions that's out there in our disease management healthcare system is the care is very siloed. And so if you see a surgeon, they do surgery. If you see a internist, it's a pharmaceutical intervention. If you see a therapist, it's just manipulations or therapy, and you're not getting integration of care where people are addressing the 3 things that are required to have consistent, reliable, predictable outcomes. And it's addressing the structure, the function, and the behavior. So the structure would be, for example, where you have an individual has a crossbite, high palatal vault, a deviated septum, swollen turbinates, they can't breathe through the nose, bimaxillary retrusion, their face did not develop enough, they have adenoid faces, as an example. So those are structural risk factors that could be addressed surgically and non-surgically. As far as function, you're going to have compensation. The swallow, how they breathe, where they keep the tongue. Are they mouth breathing? Are they nose breathing? So those are functional issues that could be addressed with what's called myofunctional therapy. It's nothing new. It's something that the rest of the world is ahead of the United States in doing, with many studies and a lot of evidence to show that you can repattern the oral posture, the tongue, being on the roof of the mouth, which is where it should be.
Quick thing. So I've done probably over 100 interviews of sleep professionals.
Yeah.
And it took me until literally number 98, 99, 100 to run into 3 people now that talk about this myofunctional therapy. But until then, even I never ran into it. And I'm actively looking and interviewing people like you. So I think it's probably pretty rare that anyone gets to the point where they're not just say, oh, you need a CPAP, oh, you need a sleep study, oh, you need a dental appliance to advance your jaw. I mean, I know this is the world you live in and everything, but I would guess, just based on my experience, which has, again, been focused in this area lately, is that it's rare that most people will be aware of this, and it's rare that most people's doctors will be aware of this. It's just my experience.
Right. So I'll just say that the problem is that in a disease management healthcare system, it's not recognized because they're treating signs and symptoms. So it is nothing new. And in my world, yes, it's a self-selected population. It's known. People know that this is what they have to do. Brazil has done studies now, PhD level studies, systematic reviews and meta-analysis and original studies actually showing this. It's being recognized now by Kristen Guilleminault, Kikushita at Stanford School of Medicine. There are studies regarding the use of the didgeridoo to increase the muscle strength in the pharynx that actually repatterns the brain. So it's not just the muscles, it's actually changing the neural connections at the level of the cerebellum that function to give us our respiratory reflexes and breathing mechanics. So that's the problem is that people aren't addressing that, and they poo-poo it. Now the evidence is very, very strong. And so I'll just say something that I think that's even less understood. So that's structure, that's function. The third thing is breathing behavior using a capnometer. So that's an issue that every one of these patients has disordered breathing at night. That's why it's called sleep disordered breathing. Also have disordered breathing during the day. So it's how they ventilate. So they're chest breathing. They're not moving the full oral tidal volume, and they're in a chronic state of respiratory alkalosis. So they're blowing off too much CO2, and that stimulates sympathetic drive. So all these individuals are in this low state of sympathetic drive that's causing a lot of the signs and symptoms. In fact, it's what's making them sick, and they're not aware of it because that's all they know. So anybody who's taken yoga understands how they feel. They feel relaxed. Why do they feel relaxed? Because essentially they've been able to take an hour to pull themselves back into parasympathetic coherence, which is the way every mammal is supposed to function. But as soon as they leave the gym and they stick their keys in the ignition car, they're back into that sympathetic drive, that disordered breathing, because they have this respiratory pattern because they have what's called low end tidal CO2. And you can measure that with a capnometer. And there's lots of science to support its use. And so that's one of the things we also measure is their end tidal CO2 and their breathing pattern.
So what are you called then? If someone's looking for, someone has sleep problems, they're waking up tired, or, any others, normally people say, oh, I need a sleep doctor. But is that what you're called? Or how would people even find practitioners like you that look at all these things?
Well, I say that disordered sleep is just a symptom. It's treated as its own entity, like type 2 diabetes, treated as its own disease. But it's actually a symptom of which fragmented sleep is a major risk factor. So I would say that I'm addressing breathing problems. People come in with breathing problems, of which fragmented sleep is only one of the symptoms.
If I have a problem, I think, okay, I can think a couple things. I can think, I'll just go to my primary care doctor and then he'll help me. And the primary care may say, you need a sleep doctor, or maybe you need a pulmonologist, or maybe you need ear, nose, and throat. How do people identify that they need you? I mean, so you're listed as a D.D.S, which is a dentist, right?
Well, right. And so that's why we train dentists. Actually, we train physicians and allied health professionals as well. I work with well-known sleep physicians, pulmonologists, and ENTs that this is their world, and they agree with what what we're teaching, what we're saying. The average physician knows very little about it. They get 1 hour of sleep science in medical school. So when people come to me, what we as dentists, what we're actually seeing are the signs of disordered breathing and sleep. And so we have to start recognizing. I'm working with the ADA right now. We're actually changing the way we think and the way we train regarding that. So when people come into me, it's how you talk to them about it. I ask questions, we do screenings, and we get data, and then we put it all together. So now I'm getting people who come in and they've seen the ENT and the sleep physician, the pulmonologist, and the system has failed them. They know they have this problem. They know they don't have Lyme disease. They know they have fatigue and this fragmented sleep, and they don't want a CPAP or even an oral appliance. Those are interim management tools. I think it's necessary to manage the problem first. So if someone presents with a femoral artery that's ruptured, you have to put a tourniquet on to save their life. And that's what I see CPAP and oral appliances to do. But eventually, you want to get into definitive care to address the underlying etiology. And that's basically what we train.
Right.
What could we do to get them off of that and to cure the problem? So medicine can manage, and they must manage it. Dentistry can cure it.
Okay, no, that's great. So how would you, I interrupted you, took you off track on all the things you look at, but, you're also saying them in a technical way. Can we restate the things that you would look at just in the plainest language possible, maybe the language that you would use with a patient? So you may want to say, we want to look at the size and the dimensions of your airways, your nose and your mouth, et cetera, to see if, that's creating a blockage, or, how can we restate the things that you will look at in, like I said, very plain terms?
So usually patients, when they come in a dental office, they already have signs and symptoms and complaints, whether it's temporomandibular joint dysfunctions or disorders, or they have, fractured teeth and lost teeth. So they have dental signs that as a trained airway-focused dentist that they're related to their airway function. So your job is to communicate it in a clear, simple way that the patient gets it, and they do. Once you explain it, they do understand that the teeth are the canaries in the coal mine, so to speak. They're just kind of a victim of a bigger problem. And so I always talk to them and address them by saying we have to address, the hardware, the software, and the operating system. So the hardware would be the structure, the software would be the function, and the operating system is the behavior. And behavior is physiology in action. And so they get that. And I'll give you an example. So let's say a patient comes in, and how I started connecting these dots many years ago is in my demographic, pretty privileged socioeconomic area, educated people. I was blown away as to how many of these patients were on anxiolytics and antidepressants. Why would you be on those medications when life is good? So let me give you an example of how I would talk to a patient about it from a dental point of view. So I have these 3 different caliber straws, and I would give them a large straw. And I'd say, Mr. Jones, I want you to breathe through this large straw. And while you're breathing through this straw in your mouth, pinching your nose, I want you to imagine that your head is underwater, just under the surface. And I'm going to ask you how you consciously feel as you're breathing from the straw. And my guess is that as you're breathing, you're feeling okay. You're getting enough air pretty easily. Is that correct? And they shake their head and they say, yeah, I could do that. Okay, maybe it's not a snorkel, but they could breathe well enough and they could imagine there's no threat there. So I'll take that away from them and I'll give them that regular straw that you use to suck up a malt or a milkshake. And I'll ask them, how are you feeling now? Again, breathing through that with your nose pinched underwater. My guess is that if you were doing that for a few minutes, you'd start maybe having some anxiety, right? And then I'll hand them the little coffee straw and say, well, how do you feel now? They don't even put it in their mouth. They're already anxious just thinking about it. So I try to make the distinction between psychological anxiety and physiologic anxiety. And people conflate the two. They don't make the difference. They think it's their wife. They think it's the traffic. It's their husband. It's the school. It's, et cetera, et cetera. That's what we call life. That just exacerbates it. There's language for it, so you can understand that. But the autonomic nervous system or the brainstem does not have language. You have that limbic response, that feeling of anxiety. And when you threaten it in any way, it's a survival mechanism. So if you have a small airway, inadequate structure, and the soft tissue compensations, you can imagine how that anxiety that results in these functional somatic symptoms can result in that. And they understand that intuitively. Oftentimes they start crying in the chair saying, oh my God, I knew that's what it was. And so our job then is to address the structure and functional issues to where you could predictably get them feeling well. And we do. CPAP is not going to address that very effectively. The way the physicians are dealing with it is giving them an anxiolytic. They don't recognize the problem for what it is. I could delve into all the research having to do with the effect of chronic intermittent hypoxia on the brain and how it actually destroys the white matter, causing depression, a high correlation with depression. The same thing with anxiety. The well-known Australian Deloitte study in 2011 actually showed the effect that it had on those symptoms on the gross national product. So it's a huge economic problem as well. So we could go on and talk about all those correlations. All they're doing is they're treating symptoms. And I just say, let's step back and take a more global approach to what's actually happening rather than chasing signs and symptoms. Let's see what's happening with the entire organism from a global point of view.
And I guess the big point here is that just because someone's a child, 5, 10, 15 years old, doesn't mean that they're immune from any of these things. And
no, that's when it starts. That's when it starts. In fact, there are studies to show it starts in the 3rd month in utero. And we actually have a fetal and maternal initiative that's actually screening moms during that 3rd trimester because there's a high percentage of those moms that are suffering from sleep disordered breathing that has downstream consequences to the fetus. Increased risk of preeclampsia, gestational diabetes, small for gestational age birth outcomes. That data is already out there. That's where it starts. And then postnatal, looking at their swallowing reflex, their primitive reflexes. And so we go from that point all the way through. By the time you get into, a 20 or 30-year-old, they've already been suffering from this for a long time. It just wasn't recognized for what it was. And the data is super strong. I mean, this isn't anything I'm making up. It's not being integrated.
Oh. So what are some of the interventions you've done as examples for people, and what was their experience once you did them? Maybe pick a couple of the most common or most deleterious things that you've seen, and maybe just comment on a couple.
Okay. So on one end of the spectrum, from the most invasive, that someone has moderate to severe sleep apnea, maxillomandibular telescopic orthognathic surgery in combination with myofunctional therapy and breathing repatterning on one end of the scale. Those people are predictably cured from the problem as measured by the gold standard and their reported signs and symptoms. It changes their lives. They turn into a different human being, and they'll tell you that. Dozens and dozens. I could tell you the interviews. I could show the outcomes. We measure everything. On the other end of the scale, a 9-month-old, I would work with knowledgeable airway-focused sleep and language pathologists that understand the primitive reflexes, the deglutition patterns are manifesting because they can't breathe through their nose well, or because there's lip incompetence. To in between what I call the skinny woman syndrome, the 22-year-old college grad that is suffering from mood swings and anxiety and irritable bowel syndrome and TMD and bruxism. Someone like that, the first thing we do is we stabilize sleep, and then we address structure, function, and behavior. And it may be that we do orthopedic remodeling to address the midface deficiency in combination with repatterning the tongue with myofunctional therapy and doing breathing repatterning. So there's so many tools that dentists have at their disposal to address that beyond surgeries, medications, and devices. We're just using surgery, medications, and devices because that's all we know and that's how we were trained. And yet there are all these validated approaches that are very, very effective. And in fact, we go through monthly case reviews. Our team does. We have an interdisciplinary team where we go through these case reviews on a regular basis, and we actually teach that. And we have web-based meetings where we train the clinician to present the examination profile and their treatment sequencing, and then we all work as a team from the pulmonologist point of view, from the otolaryngology point of view, from the orthodontic point of view, from the myofunctional therapy, from the physical therapy point of view, from the craniosacral osteopathic point of view, all have a stake in understanding what's going on with the patient. It's not just one person, and that's what makes it difficult.
So what happens if, I know you can't see everyone in the world. What happens if people are not local to you?
Well, I have people flying and driving from all over the country and internationally now. You know, my greatest efforts right now are to train other people, and we actually have a healthcare model called the Be Well Collaborative, where we're setting up these interdisciplinary facilities all over the country, following our specific algorithm, where the patient is evaluated by the seat physician, the otolaryngologist, the orthodontist, the restorative dentist, and the therapist. And they could go in, and a lot of it is web-based. So we have telemedicine, telemyo, telebreathing. We're establishing a teleradiology, so we can actually get data from South Africa or from Malaysia, and we can actually, as a team, look at it and say, okay, here's the things that we would do. We're in a digital world, so there's a lot that we could do. Everything's planned digitally as well, using cone beam tomography, using digital scanning. So we have a lot of technology that allows us to really evaluate these patients anywhere in the world. And just putting the pieces together in treatment sequencing is, where the challenge is, depending on where you are, where your wherewithal is. A lot of people will fly in, but my hope is that we could do this as a standard of care everywhere. And that's where I see us in the future going right now. It's exploding worldwide. So it's interesting that you say that you've been interviewing a lot of people and you've only heard a few talk about myo. In my world, I'm connected to a global network that is very well aware of this, and there are international conferences looking just at myofunctional therapy. The AASM is one of them, IAOM, the AOMT, and I could give you a lot of organizations, and it all comes down to connecting. And so your efforts in interviewing individuals is part of, I think, the intellectual infrastructure that's going to make it happen. You're connecting people from a lot of different disciplines and understanding to really address what I call knowledge voids. And that's what we have to address right now. The information's out there. It's just getting it all connected and then integrating it.
Yeah. I mean, talking to you is like speaking to someone that brings up, you brought up all these things that I've only heard a little bit about, and a lot of them are new. And it sounds like you're like, of course, there's all these things you can do. And, and I'm telling you, most people have no clue about any of these things. They may not even know what a CPAP is.
Right. So from your point of view, you're interviewing a lot of people, but if you get into the context of where we are, I mean, you're dancing around the mainstream, and the mainstream's kind of missed a lot of, because it's all about disease management, and what we teach, the first number of hours we teach is how we think is part of the problem, where we get our education gets in the way of our learning. And so, we could go through many hours of discussions on what the problem is. The problem is really how we see the problem. And, we could spend a lot of time, and it is.
I don't want to, again, I'm just one person, one family, but, I've been to the dentist. They don't say a word about this. My daughter's been to the orthodontist, nothing. My wife has been to the dentist, nothing. My friends, I've never heard any of this from anyone at all.
Yeah, there's a big grassroots effort. If you want to look up, you could Google Documenting Hope as an example. Beth Lambert, looking at children. So this is the first generation of kids that's going to not live as long as their parents. We have an entire population in the United States of kids that is sick, not just a little sick, but they're really sick. More autism, more ADD, ADHD, more metabolic dysregulation. So you have to ask the question, what's going on with our species? And ultimately, one of the underpinnings of what we teach is that it's our environment since the Industrial Revolution that is making us sick. So if you look at the data from the World Health Organization, worldwide, you're finding that more people worldwide are dying from diseases and conditions that didn't exist 100 years ago, didn't even exist 50 years ago. They were dying of infections, tuberculosis, dysentery. That's pretty much under control. We're now dying from conditions that we've created in our modern environment that we did not evolve from for eons, that we can't cope very well with, from lack of sleep to what we eat to what we breathe. So we can get into the whole topic of epigenetics, but with the time, it's just mentioning the word, that's really where the problem is. And so it's affecting our kids. And so the United States ranks number 50 in the world in its population health, and yet we spend more than twice of any other country. In 2011, we spent $2.7 trillion. It's unsustainable. It's going to take us down. We cannot continue to do what we're doing unless we change our healthcare system in whole. And I could give you so many references and organizations that understand that. And so that's a whole other discussion. So, yeah.
No, that's great. That's fantastic. Just a couple more questions. You gave an example earlier about, one of the most invasive ways that you may have to intervene to help someone. What are some of the less invasive ways? Maybe like 2 examples.
Oh, myofunctional therapy. You could have a myofunctional therapist that could be a hygienist who's gone through the proper training, to a physical therapist who's gone through the proper training, to repattern the swallow and the oral posture and foster nasal breathing 90% of the time. But it does require work from the patient. It's not a magic pill. You're not going to take a pill a day and you're going to be fine. You actually have to do some work to change what got you sick to begin with, the poor sleep and breathing to begin with. Another example would be perhaps craniosacral therapy from an osteopath or craniosacral therapist that addresses those issues that are related to the cranial structures that are also potentially a problem. You could do the breathing repatterning with behavioral capnometry, a master's level therapist that understands the physiology and the chemical axis from underbreathing or overbreathing. We all know that overeating is not healthy. Well, overbreathing is also not healthy. It's just as bad. And most of our population is overbreathing. It's what's causing that sympathetic, upregulated drive that leads to adrenal fatigue. That could be repatterned by behavioral capnometry in just a few weeks.
What is overbreathing or underbreathing, by the way? What's an example of that? How does someone overbreathe or underbreathe?
High percentage of our entire population is definitely doing that. It's kind of like hyperventilating, but it's more nuanced. You just don't know you're hyperventilating. So if you had a capnometer, it's what's used in the OR to check someone who's under general anesthesia. So medical capnometry is well-validated medical instrumentation looking at end-tidal CO2, which is the amount of carbon dioxide reserved in your lungs. And everybody should have a minimum of 35 millimeters of mercury of pressure within their lungs. And that could be measured, but a lot don't because they're overventilating. And why that's important is that hemoglobin releases oxygen, the brain or the muscle or the organs, as a function of the CO2 gradient. And if you're over breathing all the time, it's going to cause disordered breathing and you're going to over ventilate. And that's going to stimulate the sympathetic drive at the level of the brainstem. Well, you can repattern that with instrumentation and find out from the patient why they have that behavior. It could be that every time they're in an interaction with, let's say, somebody that threatens them, they start, becoming fight or flight, sympathetic, and every time they're in a situation similar to that, they have this behavior that they're doing that and they don't even know it, and it's eventually making them sick, and they think that it's the traffic or their workload, as an example. So they have these triggers that stimulate that overbreathing, and then they try to sleep at night and they can't fall asleep because they have too much norepinephrine or adrenaline in their system. And so by the time they fall asleep, the alarm's going off, and then they start the cycle all over again. What do? They reach for a venti Starbucks, and they end up waiting till happy hour, and they want to talk themselves off the ledge. How do they do that? With happy hour, a beer or Chardonnay. Now, don't get me wrong. I'm not saying that you shouldn't do that, but it's a way that they kind of try to chemically get themselves into that sweet spot to feel okay, but they're not well. We have a whole population. That's what's making us sick. Read the book, Robert Sapolsky, Why Zebras Don't Get Ulcers. He's a very well-known neuroendocrinologist that he's written a lot about that. He studied baboons for decades in Africa, looking at the stress response. You could read Daniel Lieberman, who wrote The Story of the Human Body. He's a very well-known anthropologist from Harvard. He wrote that book, as well as The Evolution of the Human Head. Talks about exactly the same thing. Breathe Well, Be Well by Robert Fried, that talks about how 60% of emergency room visits in large cities are the result of dysfunctional breathing. So there's a lot that's been written about it. It's just that people are going to the primary care physician and they're having their symptom du jour treated with the medication, and no one's really looking at the underlying problem. And you know what? There's this grassroots effort that a lot of people are getting frustrated with the current disease management healthcare system. There's a chemical solution for every symptom. And so we could go on into what the problems with a broken system in disease management is, but you kind of get the meaning of what I'm trying to say here, hopefully.
Well, yeah. I mean, for instance, just for listeners, I did a Google search for myofunctional therapy as I was talking to you, just to pull it up, and I see ads interspersed in there. Can't sleep? Take this pill. Can't sleep? It's everywhere. I understand. I mean, WebMD and all these things have been invaded by this. It's all over TV and everywhere. I totally agree. And that's a far inferior way than finding the root causes and fixing them. So yeah, I got it.
A lot of the population that listens to you say they may not know about myofunctional therapy, but they know about the problem that we just described. And I think that's the start. They just don't know where to go. And I think education, like with everything, is part of the big part of the solution.
Yeah, definitely. Well, this has been great. Really, really great interview.
Thank you.
If people are local to you, you're in Orange County, California?
I'm in Orange County. They could go to D.D.S.com, and in there, I've got a website tab called Airway Focused Dentistry, and on the main website with literally probably 50 educational videos from a lot of different perspectives. And for me, I'm not necessarily about getting the referrals. I have a very, very busy practice. I'm about getting the word out and educating people like yourself. I'm going to die and I'm going to be going somewhere else, like my dad would say, to the big molar in the sky at some point in time. But the problem remains. So if we could leave the place a little bit better than we found by educating, then I think we've done our job. So they could go onto my website to learn more. If they want to contact me, the information's there. I'm more than happy really to promulgate this knowledge and really to help, like getting out there and doing our part and trying to help healthier U.S. public and beyond. So
yeah, no problem. And if people either go to your website, is there a place where they can find practitioners that are trained as you have been trained, or are you not at that point yet?
Yeah, I have a whole network of practitioners I've trained from all over the world that's gone through our rigorous program and that continue to. We have a big group coming from Europe and South Africa and Asia this next fall. So we have people from all over, and I'm happy to connect. So they can contact us, and I'll try to find somebody near them or help them find out where they can go to get the answers that they need.
Okay, well, excellent. Well, thank you again for coming. I really, really appreciate it.
It's absolutely my pleasure, and good luck in everything you're doing. Thank you for what you're doing.
Oh, no problem.
You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and share it with friends. Thank you.